Hello. Today I'm going to be talking about amputations and the role an OT may play during the rehabilitation phase of somebody who has had perhaps a recent um, amputation. So for the learning objectives, students will understand the OT's role in rehabilitation of somebody with an amputation. Students will relate occupational performance challenges for someone with an amputation. And this one actually meets an accreditation standard that students will gain the ability to train a potential client in donning and doffing and upper and or lower extremity prosthesis. So you'll likely see that one on an exam. So the causes of amputations vary. Sometimes they can be congenital, they can be traumatic, they can be some a result of some vascular disease. I'm thinking of diabetics. They can be related to tumors or even complicated infections. There are currently 2 million people that experience limb loss. 185,000 in the United States have amputations every year. And that at-risk population tends to be men between the ages of 15 to 45 years of age. And when you think about our culture or society, men between those ages, they're usually more work-related types of injuries. Certainly in the upper Midwest, we see a lot of farm-related injuries, those kinds of things. For the different levels of amputations, I'm assigning a video with Art. He is an OT who has had bilateral amputations. And so it is somewhat of a dated video, but he still goes over the different definitions of what a forequarter amputation would be: a shoulder disarticulation, transhumeral elbow disarticulation, transradial wrist articulation, and a partial hand amputation. So those are just the different levels of amputation relating to upper extremity, of course. Um, and so the rehabilitation of somebody who has an amputation is going to be a team approach. And it's going to happen in stages or in steps. Obviously, if somebody has a traumatic amputation where they sustain some type of an accident and their limb is removed because of that, um, there's going to be some acute phase where they're going to have to heal and those kinds of things. Um, at this point, we may try some pre-prosthetic types of therapy, which occur right after surgery, and it sort of takes them step by step to prepare them for a more useful, more functional prosthetic. Pre-prosthetic therapy, again, may address any wound care. There would likely be sutures closing up that residual limb. You would be educating them on maintaining skin integrity and how to keep that wound clean. You would be looking at maintaining any joint mobility that they may have. So if they have a below the elbow amputation, you'd still be working on that joint mobility of the elbow, as well as the shoulder, and not forgetting all of those other components. Like we know with biomechanical frame of reference, we would be dealing with edema, maybe some elevation if we can do that, some edema massage. We would be helping with scar management that could be relating to some scar massage and pain. It could be suture pain, it could be other types of pain, such as a phantom limb pain or phantom limb sensation. This is the continuation of sensation in that missing limb. It's quite an interesting phenomena where somebody has an amputation and they still feel as though they have their full or their residual limb, they still feel they have the full limb there. Some of the treatments that we've seen for phantom limb pain or sensation is something called mirror therapy, and this is where a mirror is placed in the midline so that limb, their residual limb looks like their full limb because they're actually seeing the image from the mirror of their unaffected side. And so then they would be going through different movements bilaterally to try and get their brain um, to sort of connect with that affected limb. There are certainly psychological aspects with amputation, and I think right at this pre-prosthetic part, again, it's more of that acute phase. And so I think the psychological aspects hit pretty hard. There's certainly going to be changes in function if they're missing part of their limb. Their whole appearance is going to look differently. They may have to change roles, which could affect their overall self-esteem, their feelings of confidence, their self-worth, their body image. They may be going through shock, right? This didn't happen to me, or disbelief. They may feel helpless or hopeless. There tends to be higher incidences of anxiety and depression. And so these psychological aspects certainly can vary from person to person, but a therapist should really encourage that open and honest discussion with their client, developing a relationship with them built on trust, built on respect. And I think if you're working with other team members, just to make sure that the patient has information when they're ready to receive their information and to revisit. I always think how if somebody's in shock and in disbelief, and you're trying to tell them, oh, look at this prosthetic. It has, this feature, that feature. It'll help you do this or that or this or that. And they're still in grief and in disbelief or shock. They may not be ready to comprehend that at that particular time. So just be mindful of that and try and get to know what the client needs or wants, right? I have a video later on that really shows, I think, a lady doing some of her stitching and those kinds of things. And so, what is it that they want to be able to do, or what do they have to do in order to be independent at home? And so, those kinds of things we should be finding out from our client, and then trying to help them see and have hope that there's possibility after their amputation. It's always helpful to help them find somebody who's gone through a similar situation. So if there's any support groups out there, any reference materials out there to help cope or help adjust, maybe to any prosthetic options, any tips on managing their independence, maybe organizations, anything else that maybe you or your team that you're working with can come up with based on what that client needs and is hoping to achieve. Some of the pre-prosthetic program guidelines, and so of course you want to be able to provide some emotional support, listen to them, listen to their needs, their concerns, try and find answers for them. Again, typically it's not done just with OT, there's a whole team approach, and so you'll have to communicate with everybody on that team to make sure that that client's needs are being met. Limb hygiene will be really important. So their incision or their part of their residual limb may still be healing. So making sure that we can educate them on how to properly perform hygiene on it. There may be soap, it may be keeping it dry. It'll likely depend on the surgeon and what their protocol is. They will likely have to undergo some type of limb shrinkage and limb shaping. And so this is where the use of elastic bandages or maybe an elastic shrinker is placed over the residual limb. So many times there will be some swelling. They're going to have to, reroute some of the musculature that's left, and those kinds of things. And so what they really want is they want the end of that residual limb to be tapered. So to be thicker on top and thinner on the bottom. And so with that residual limb likely hanging down, gravity is going to be pulling some of those tissues into that lower position. Edema is going to be trying to pool in that lower position. Scar tissue is going to be forming and building up that area. And so using wrapping or shrinking that limb is going to be very, very important in allowing that limb to fit into a future prosthetic. And so this is a great video by an OT who has a lower extremity amputation, and she talks about the shrinkage and shaping protocol that she has underwent. It shows you more of the elastic shrinkers. In more of the acute phase in like a rehab hospital or acute care hospital, they may not have those shrinkers readily available. They may be starting with some type of bandages. And so in your reading assignment, they have specific directions with pictures on how to wrap that residual limb. And so the key part of that wrapping is to make sure you're not doing it in a tourniquet or going round and round type of fashion, because that would likely decrease the circulation. And so there's more of a figure eight type of wrapping for that residual limb. The benefits of using a bandage and doing the wrapping right away in that acute phase is because the swelling will eventually go down. The tissues are going to shape and change their shape based on the wrapping, which is what we want. And so during that acute phase, that limb is going to change quite rapidly. And so if we have bandages and we know how to wrap, we can accommodate for that, right? We can change those bandages quite frequently, and we can make them tighter as we need and kind of progress them. When they become more stable, then we can start with more of the elastic shrinkers, so we don't have to change those quite so often. We'll want to start them off with a prosthetic as soon as possible. Typically, we start them off with something quite rudimentary or quite, what's the word I'm looking for? Simple, not very complicated. And we just want to try getting them used to some type of a wearing schedule, okay? So if we can get something simple fitted to them, starting off maybe in 15-minute increments, anything like that, and gradually increase that time, the greater likelihood it'll be that that patient eventually accepts whatever prosthetic that they'll get. So again, starting off with something very simple, getting them to, if it's an arm, getting them to do more bilateral hand tasks with it, using it more for stabilization, those kinds of things. Again, very simple, just trying to increase a wear schedule, get them to start thinking about using something along those lines, can certainly help increase the chance that the client will accept that prosthetic. Sometimes there's lots of pain. I'm thinking of some clients I worked with. They had a lot of pain over the healed scar. And so having that shrinker over that scar was very, very uncomfortable. And so going through some desensitizing techniques was something very important. Desensitizing techniques, there's some examples in your reading assignment on those particular pages, but it's basically a protocol for you to follow that meets that client with what they can tolerate as far as tactile sensation goes on their residual limb, and then doing some techniques that gradually desensitize that residual limb. And so let me see here if I have some examples jotted down. And so desensitizing may start with just some simple pressure, tolerating that pressure, maybe with an elastic bandage for the wrapping, maybe doing some light tapping over that limb, doing some rubbing. Um, I like to use like the dried beans, right, and pouring that over the residual limb, the dried corn, the dried rice, um, using washcloths, those kinds of things, kind of moving up towards more of a friction massage. Um, or scar tissue massage. Those kinds of things can help. Any vibratory tools also that give that vibration that can help desensitize also. And so it's something to kind of help that client and train that client's brain into, okay, this should not be hurting now. I'm seeing this happening to my arm and I see that it should not be causing pain. And so you're trying to use that mind-body connection to desensitize that residual limb. During this pre-prosthetic program, we would also be maintaining any range of motion or even increasing range of motion and strength from whatever joints and muscles are left. And of course, we want to maybe teach some adaptation skills to facilitate independence with activities of daily living. So adapting on how you get yourself dressed. Maybe it's more unilateral techniques if you are missing an arm. Maybe it is more using adaptive equipment like an adapted cutting board or an adapted setup um, for doing sewing or cross stitch or writing or typing or any of those kinds of things. We also may help facilitate changing your hand dominance. Okay, and so this is something that I think one of the videos I have showing you guys that I want you guys to review. There's a gentleman who talks about being right hand dominant and how he had to have a conversation with his other hand and say, okay, now you need to be the dominant one. And it takes a lot of time and repetition to retrain your brain into changing that hand dominance. And so in the literature, there's actually a program. It's a 6-week handwriting program for adults to retrain or to teach or to retrain handwriting with your non-dominant hand. And it's called Handwriting for Heroes. And so again, it's a 6-week handwriting program for adults that's been showing some good promise to change that hand dominance if needed. Bilateral amputations can be, as you imagine, they can be quite complex, right? I'm thinking of bilateral upper extremity amputations. I mean, we just use our hands for everything, right? For grooming, hygiene, cooking, bathing, driving. We use our hands for so many things. And so we really want to try and be or allow our clients to be as independent as possible. The sooner the better. It's not uncommon for people with bilateral amputations to really feel hopeless and helpless and to kind of learn that learned helplessness. Right? I can't do it. I don't have any arms. You have to feed me. You have to change me. You have to do this. You have to do that. And so they heavily rely on other people. And so if we can fit them early on with a temporary prosthesis, just so that we can get them using whatever residual limbs they may have. And it may be putting that temporary prosthesis on whatever longer residual limb they have. Okay, and so um, depending on the injury, depending on where that amputation is at, certainly the higher up the amputation, the more difficult it is. But you would want to work again with that longer residual limb to try and get them fitted with a prosthesis to get them using them as much as possible. There's many different adapted devices out there. And so I remember a little girl I worked with in Peru. She was born with bilateral amputations. And so they had tried giving her some upper extremity prostheses that were donated to her. I don't believe they fit adequately, and she just didn't ever want to use them, so she just never accepted them. That little girl was fascinating. I mean, she wasn't so little. I believe she was around 10 years old at the time when I first met her. Um, but she had all kinds of adapted techniques with writing and painting. She loved to paint, and so she would hold um, a paintbrush underneath her or in her mouth, and she would whatever residual limb she had, she could use as a stabilizer, and she would just use her head and her mouth to paint as much as possible. To help grab things, she had one leg, and that she did use a prosthetic for, and then the other leg was there. And so she would use her feet to help her grab some things as well. Um, and so she really was quite remarkable. She would have a pencil in her mouth um, and a pen in her mouth, and she would use, and both at the same time, and she would use the pencil in her mouth with the eraser facing towards the paper or the book, which was on a slant board, and she would use the pencil to turn the page, and then with the pen, she would write with the pen in her mouth on her notebook. And so again, she had a pen and a pencil in her mouth. She used the pencil to turn the page of her textbook and the pen to write. It was quite legible. Her painting was really quite remarkable. Something for her that was impossible was self-feeding. I mean, there was nothing for her to help with self-feeding, and so for many years, she had an aide, somebody in the cafeteria, or a teacher, or another student feed her. Her parents fed her. And so when we went to work with her, one of our students actually took a piece of neoprene and sewed on some Velcro so that it became a strap to go around her residual limb. Then they took a heat gun and they heated up a spoon and they bent it. And then they sewed a little pocket on that neoprene um, tourniquet or wrap. It wasn't a tourniquet, it didn't cut off her arm. But then they had it tight enough, and with the angle of the spoon, she was able to scoop on her plate and bring the spoon up to feed herself. And everybody cheered because this girl who was 10 years old, had never been able to feed herself, could actually feed herself. And so I went to Peru a year later, and they were still using that same device for her, and they had made one for her at home. I think they wanted one of our students to make another spoon for her to like heat it up and to bend it and those kinds of things, so they could change it out more regularly. So that I think was one of the most rewarding things that I saw in Peru. And again, working with that longer residual limb, right? And maybe adapting a device for her allowed her to be independent with something she wasn't able to. So very, very cool. Choosing a prosthesis is typically a team approach. It's going to depend on the residual limb length, of course. So again, the more proximal the amputation, kind of the more difficult it is for that prosthesis, or the more complicated that prosthesis is. And the video that I'm going to have you guys watch, there's a lady, an older lady, who has an upper arm amputation, and so there's actually a strap that goes behind her head, and she can work it with some shoulder elevation and those kinds of things to get her other arm to work. So again, it just kind of depends on when you choose a prosthesis, it's going to look different based on what limb length you have to work with. Again, taking into account what our client wants or needs. Um, and again, I really liked the upper extremity video for this. Is it more of a cosmetic prosthesis? So somebody doesn't want to look different, or is it going to be more related to function? And so in the video, there's a lady who has a arm, an upper extremity prosthesis, and it actually looks quite real. It's pretty good. Now there's some functional components to that prosthetic too, which is nice. So some cosmetic prostheses don't exactly have function to them. Their function is just simply to look normal, so they're not catching other people's eye, and maybe it makes you feel a little more self-confident and not as self-conscious and those kinds of things. Again, knowing what that person wants to do or is going to have to do for maybe work, for school, for living around the house, that would certainly help what kind of function or what kind of prosthesis that client may eventually want down the road. Considering hand dominance. So if you're right hand dominant and you still have your right hand, maybe your left hand prosthetic is more for cosmetic, right? Maybe just being able to use it for a stabilization or stabilizer is functional enough. Considering what the client's prior level of function was, that kind of would help you also determine something for maybe cosmetic or function is also something important. So in the video, the upper extremity video, there's a guy who's like rock climbing, right? And he's like, yep, it needs to be rugged, it needs to do this, it needs to do that. And so considering what his daily occupations are and what he needs it for functioning, and that's what he was doing before, certainly we want a prosthesis that will help them do what they were once doing before. Again, maybe activities at work, home, school, community, and certainly for recreation as well. It's obviously we'll have to take into consideration the patient's goals and motivations. What do they want to be able to do? And also any financial coverages or fundings. Sometimes prosthetics can be very expensive. A lot of times they are covered with insurance, or workers' compensation, those kinds of things. However, when you start getting into more of the advanced prostheses, those kinds of things, they do run quite a bit, or they are very costly. And so the insurance company may pay or may reimburse for maybe a lower end prosthetic to get that person using something and functional. But a lot of times that's not the only prosthetic those people need across their lifetime. So, they kind of start with something very simple and then maybe learn to progress a little bit farther. They may need another surgery to kind of reroute their nerve endings to get a muscle belly to fire in a particular area, so that a higher level prosthetic could be used. And so, depending on all of those things and where that person's at, coverage could be rather challenging. There are some agencies and organizations out there that might help cover the cost of certain prosthetics and higher level prosthetics and those kinds of things. And so it's good to see what's available in your community um, and go from there. Cognitive abilities are also something that would help us choose or help the team choose what prosthetic is appropriate. So um, some of the components can be very, very, very complex. And so if somebody has some cognitive impairment or intellectual impairment, you'd probably want, or the team would probably want something a little less complicated, just so that they can functionally be able to use it and it actually impacts their life for the better. Prosthetic systems can be a body powered system, and so this is where you would use motion from the body, actually proximal to that amputation. Okay, and that is going to help operate that terminal device. And so that's something where, you hear people doing like the shoulder shrug, and then that opens up like the hook. That would be the terminal device. And so the terminal device is what they called the piece that replaces the actual hand. An externally powered system uses myoelectric systems, and so this requires electrical signals produced from muscle contractions to operate a powered terminal device. And so these are the ones that perhaps don't have the straps, but they fit over. Um, and then if that client can get the bicep to contract, it will actually open up the terminal device. If they can get the muscle belly to contract to like do more of a supination or get it to contract another way, then it's going to supinate that terminal device. And so these are really quite cool types of systems. There's usually electrodes inside that really target what muscle is still available. Um, it requires some training. It requires some strengthening also. Um, so they may actually, in surgery, there may be a surgery where they actually take that nerve to innervate whatever muscle is left from that amputation in the hopes that with that nerve innervating that piece of that muscle, if we can train that patient to fire that part of that muscle, that could open up that piece of that terminal device or have that terminal device do another function. So it's really quite fascinating. They do have hybrid systems where there's a combination of body powered and externally powered. So you may have like a shoulder shrug to extend your elbow. You may have a terminal device with a bicep flexion to open up the hand, or electrical signal to open up the hand. And so a lot of times there could be combinations of both body powered and externally powered systems. For certain prosthetics, they may be activity specific also. And so I've seen some that they look like hands and they're just fixed this way. And they're just simply to hold or to stabilize a cup or something along those lines. And so it's designed just for one particular function or activity. A passive prosthesis is available to replace any part of a limb, and it usually does not move. I view them as fairly simple. Um, Again, it can replace any part of a limb just by offering perhaps some stability and not necessarily any adaptive types of movements. The socket design, and this is where the socket would fit into, or the prosthesis would fit into the socket, okay? And so the video that I have you watch with the OT amputee putting on her sleeve, I believe it shows you the actual socket or the pin, or it might be the other video of the lower extremity prosthesis when she dons that on and off. And so that socket design varies. So in that video, you see her actually weight bearing and you hear it click into place. And so some sockets look a little bit differently on how they attach that terminal device also. So again, they vary by system, and it's what that residual limb is actually encasing into. Um, and then that terminal device would likely fit on the end. So then we would go through some prosthetic training programs. And so this would be something maybe at an initial stage where it would be very helpful for us to look at that prosthesis. They are so different and they can be so complicated and so complex. I remember working with a couple gentlemen who had come to me for some prosthetic training, and I had no idea how they worked. And so just by giving the prosthetician a call or going there, if you can go there and say, show me how it works, or find a video to show how it works. Because sometimes that client may come to you, they've seen the prosthetician, they've had it fitted to them, they've probably gone through, okay, this is how you put it on, take it off. This you fire this muscle, it does this, you fire that muscle, you do this. And so they may have gotten the quick rundown of everything, but they may not necessarily remember how to do it or to translate that into using it for a functional task, okay? And so if you know a little bit about that prosthetic when the client comes to you, you could help them feel more competent or make them feel more confident in you. And as you're training them in the use of it, it would increase their compliance. If you notice any issues with comfort, you could certainly give the prosthetician a call, making sure the client's operating all the components and features of all of those components also. We would also teach them in donning and doffing those prosthetics. This would include maybe a limb sock, a liner. Sometimes there's certain gels or powders that the prosthetician would recommend or require before they put on the limb sock, just for hygiene, those kinds of things. And then you would place on the socket, maybe wrap the harness around, insert the pin, and go from there. And so again, one of our accreditation standards is that students need to provide education on how to don a prosthetic. And so here's a demonstration, a really good demonstration, step by step, of how an OT who is an amputee dons her lower extremity, and she includes her sock, her liner, her socket, and those kinds of things. I had a hard time finding a video on how to don an upper extremity prosthesis. I think just because they're so different depending on what level of amputation they're at. And so I thought this was a really good video. I think if you watch the first one, lower extremity, you know that it's going to still have a limb sock, a socket, a harness, and then perhaps that terminal device. And so I think you could probably figure out, depending on what prosthesis you focus on from watching the video. Wearing time is going to be different per client and what they can tolerate. And so you'll want to start off with less amounts. And by the time they get to a more complicated prosthetic, they may be being able to wear it for longer intervals. And so when you're first starting, right, and this might be that even that more acute phase where you're just trying to have something there to get them used to something foreign on their residual limb and to maybe use it for more stability. But you'll want to start your wearing time for about 15 to 30-minute intervals, and then to look and watch for skin integrity concerns. And so Are there any red spots, red areas? Okay, you'd want your client to be looking for these areas also. If there's red areas that don't go away after about 20 minutes of time, you'll want to call that prosthetician right away so that they can go and they can make some adjustments. Um, if that doesn't, if they don't adjust that, that could lead to some skin breakdown. It could lead to some pressure sores, those kinds of things. And so, again, we have to be very diligent in watching for skin integrity issues, and making sure our client is also, and then keeping track of how much time they're tolerating um, that limb time. I know for some of the lower extremity limbs, since people are weight bearing and walking more with their lower extremity limbs, they tend to use those longer or more throughout the day fairly quick. And so it just sort of depends on that client and what they can tolerate. Limb hygiene is something that's really important to keep the residual limb clean. You'll want to wash with mild soap and water, pat it dry. Now, some of the limb or some of the prosthetic liners actually are made of like a gel liner inside just to help with the friction. So there isn't that shearing force or that friction between the socket and the skin. And so sometimes that causes an increase in perspiration. So again, some people may require like a gel, which would have like a anti-drying agency or like a deodorant kind of a thing, or any powders to help keep it dry inside. Um, Sometimes just having a limb sock over or underneath the prosthetic liner sometimes helps with any moisture, those kinds of things. But I think the video also shows that limb sock needs to be changed at least daily, just because there could be some nasty bacteria in there. And again, we want to keep that limb clean, um, keep it watch for skin integrity and those kinds of things. Any componentry knowledge, um, componentry, that's hard to say, but any components of that prosthetic we want to educate ourselves on and make sure that we're reviewing with the client as well, just so that they have all of the things that they need to help them use that functionally. Another thing during their initial stage that we could focus on is how to take care of their prosthetic. How do they clean it? Do they clean it with warm water and soap and dry it? Are there any agents to avoid? Okay, so is it, keep it away from strong soaps or keep it away from rubbing alcohol, those kinds of things, or keep it out of water, right? And so some of them may have batteries that they have to replace. Some of them may have to avoid water because if they get on the electrodes, it may short out. Is there any daily maintenance that has to occur? As far as some of them have like the ropes and the pulleys and those kinds of things. And so are there any simple adjustments that could be done also if needed? So some of the ones that fit across the back and around the neck, sometimes there's little straps to make sure that that's tightened up. And so how do you tighten those? Also just knowing if there's any um, replacement parts. And so some of the prosthetics that you'll see in the video, there's different replacement um, terminal devices, which are really cool, right? You just pop off the terminal device, put a different one on depending on what function you need. And so those can be really quite helpful. We would move to more of that intermediate stage, and this is where you may have some more prosthetic control training. Okay, and so this is where you would probably educate on how to operate each of the controls of the device and practice, 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 practice. Okay, practice repetition are repetitively activating each component, trying to get them used to it. Um, that's my bird. Um, Trying to get them to functionally use um, their prosthetic as helpful as possible. So if they just have one amputation, get them to do bimanual tasks, right? With one being the prosthetic and the other being their other hand. Bilateral amputations, you'll probably have to use a lot of adaptive equipment, assistive technology, adaptive devices, right? And to use whatever you can with whatever prosthesis you're able to, and to kind of accommodate things and adapt things throughout their environment. And so um, again, one of the videos I showed, it talked a little bit about OT, and they were having him stack those little paper cups, right? And so again, that's really trying to hone in on control of that prosthetic. You know, how much do you contract to get it to close so that it doesn't close all the way and smush the cup? So it takes some refinement here. And again, it takes a lot of practice. Again, the more practice and repetition that client gets, the stronger, if there's that muscle contraction component to the prosthetic, the stronger that's going to fire um, and help reroute those neural pathways in the brain. So the practice and repetition has more to do with not just strengthening, but more of that neurological rehab also. On the final stages, and so this is where really using that prosthetic functionally, you may be looking at vocational or recreational interests, driving versus accessing public transportation, anything that you can do to help that person reintegrate into the community. So can they use their prosthesis to drive? Do they need to do a driver's rehab for it? Can they use any adapted sports? Can they use a computer with their prosthesis? Can they go shopping with their prosthesis? How many Walmart bags can they hang on their prosthesis, and where can they hang them at? All of those things we need to be kind of considering. Can they cross stitch? Can they sew? Can they quilt? Can they do any of those leisure skills? And again, we would be helping them kind of practice those things and maybe on their own. Typically, these final stages of their IADLs are completed in their natural environment, right? So we can't necessarily contrive everything or simulate everything in that outpatient kind of a clinic or a rehab hospital. And so we would want them to, or we would encourage them to go out and try and experience those as much as possible. It may be continuing to attend support groups, explore ongoing programs with prosthetics. New technology is coming out frequently. And so just kind of keeping up on that so they know what advances come out with their terminal devices. Maybe additional therapy is needed. Maybe additional training may need to occur. And so all of these things kind of help or we're putting together in those final stages of this type of a rehab program. Professional considerations, and so these are, you know, obviously outcomes. If we're using outcome measures, we want our client, or we're writing goals, we want our clients to be independent as possible. And so we could use any traditional dexterity assessment tools, like the 9-hole peg, the box and blocks. Obviously, we're not going to be using the normative data for those items. They do have something called the Upper Limb Prosthetic Outcome Measures Group. And so that's something where you probably could get some specific outcome ideas also. Outcome assessments, particularly for upper extremity amputees. In your reading assignments, they have some specific ones like the Trinity Amputation and Prosthetic Experience Scales. It's self-reporting instrument, looking at psychosocial activity restriction and how satisfied they are with their prosthesis. The assessment of capacity for myoelectric control, and so this is just a clinical observation tool for bimanual tasks with using myoelectric prosthetics. Um, an orthotic and prosthetic user survey. So this is paper pencil, measuring overall function, quality of life, and satisfaction. The Southampton hand assessment procedure, it's an assess upper limb prosthesis with 8 object manipulation and 14 ADL tasks. So again, looking particularly at a hand piece. And then the activities measure for upper limb amputee. And so an observational measure of activity performance, task completion, um, how their movement is or how skilled their movement is, how independent they are, what the quality of their movement is. And so again, no, depending on where you're working, those kinds of things, here are some specific outcome measures or assessments that are very specific to upper extremity amputee. And finally, this is a video I'm going to have you watch on your own. He does quite a bit of educational materials as far as highlighting the different levels of amputations, those kinds of things which you'll need to know. Talks through his personal experience, talks about the psychosocial, and again, it is getting a little dated. He does have a website that he kind of walks you through his journey. I find it incredibly fascinating and useful, and so I'm hoping you find value in it also, with his story and with his use of prosthetics and those kinds of things, and the fact that he's an OT. So that's what I have for amputations and prosthetics. Lots and lots of different prosthetics online for you to explore, those kinds of things. The videos I provided give you some examples as well. Art will give you some examples. And so just be sure that you are considering how you would train somebody in donning and doffing that either upper extremity or lower extremity prosthesis. Any questions, feel free to reach out, but that is all I have for you. Thank you.